Welcome everyone to this dermatology discussion that we are having of the NEET May exam. There were 10 questions which came of dermatology, so quite a sizable number that came. Out of those 10 questions, there were 3 which was an overlap with microbiology, so maybe covered even by the microbiology faculty. 7 were core dermatology, a little bit of histopathology overlap as well. So let's look at those 10 questions, right? A patient is 30 years, has a history of COVID 8 months back. Okay. She presents with hair loss since 4 months. So that means the hair loss started after 4 months. If you can get that, hair loss started after about 4 months. It could be 3 months, 4 months, depending on what the students could recall after the COVID came. Now, this is a straightforward history, and we discussed that so many times. Almost every class I discussed this when we discussed the topic of hair losses and the scalp hair cycle. We discussed the concept of anagen, catagen, telogen. And there's a slide that I show also which said that if you have very severe fever, 3 months after that fever episode, you tend to get a lot of hair loss, which is called as acute telogen effluvium. So even if you don't see the image, there is still enough evidence in all of this theory that itself is telogen effluvium. Actually, there should be no confusion. The confusion happened because some students then, when they looked at the image, they said, okay, this looks like widening of the central parting, this looks like androgenetic alopecia. In fact, I do agree that the image might not be supportive of the theory which came, though many times it's very difficult from images to look at the real cause. So I would really still bank on the theory which the question gave us, and that really did still tell us that this is telogen effluvium and not really go to androgenetic alopecia. But from purely an image point of view, you could get confused with female pattern androgenetic alopecia. But in female pattern, you would not ever have a history of COVID. You would not have a hair loss only beginning in 3 to 4 months after that COVID thing. So that is not a relevant history. So you have to obviously kind of take everything together. Even in a patient, when a patient comes to you in the clinic, you cannot only pick and choose. You cannot cherry pick one history and not look at another. You have to look at everything in perspective, look at everything together. And then when you look at everything together, this does look like an acute telogen effluvium, which obviously does not need you to even treat it sometimes. It's a self-resolving disease. And in fact, this happened a lot. And I do show you images. If you remember the images that I show in the class of somebody coming to us with a big pack of hair in their hand. And that happens because suddenly the fever has triggered that particular. And because COVID is the most common fever which came, post-COVID hair loss. In fact, it came in the newspapers also. That's very common for people to get this post-COVID hair losses. And that can be very troublesome psychologically for the patient who have recovered from COVID. They might not even remember the COVID 3 months back. You have to elicit that history and then you would get to a diagnosis, right? Anagen effluvium obviously not, because that would be there in chemotherapy. And this would be a female with having a hair picking disorder and OCD. So that again would not be relevant on this. Then the answer would be telogen effluvium, right? Second, again, a very common question which comes, and we discuss this all the time inside the theory. If you see your theory notes, in fact, if you see your notes which we create in the class, notes had all the questions covered already. So you don't have to worry if you really went through the notes properly. A patient comes with cauliflower-like growths on the foot. We do always, in fact, we even show you an image. If you remember the image which I show in the class, in fact, we draw it also like this. Remember this image that we draw in the class? This is chromoblastomycosis. And I do show almost a similar image, which is a copper penny body, right? Copper penny body, also called a sclerotic body or muriform body. These are dark pigmented bodies, dark pigmented fungal bodies. And this chromoblastomycosis is a deep fungal infection. It is a subcutaneous fungal infection, and that creates in a farmer, somebody who is barefoot, a bit of a thorn trick. The organism goes in, creates this kind of a copper penny, yellow, brown bodies, dark brown bodies, and that they can then, that's why the name came chromo. Chromo means obviously colored, and that color is there. Now, mycetoma would usually have a sinus mentioned, usually would have a grain mentioned. So all that is obviously not there. So we don't think about it. Sporotrichosis would usually be a linear lesion along the lymphatics. You would have some nodules, some sinuses along the lymphatics of the limbs. That is again not there. You would not get a chromoblastomycosis, copper penny body also, right? So that is the blastomycosis is obviously too rare a disease to even come commonly. So we are not even discussing that. So the differential is between mycetoma, sporotrichosis, and chromoblastomycosis. A patient, again, this is something that we do routinely inside the class. and we have notes also. Okay, irregular pitting, I show you the image also inside the class. Pitting, subungual hyperkeratosis, oil drop sign. I told you all the time that oil drop sign is almost pathognomic. We write that also. We write that it's also specific for psoriasis. Everything we do cover. Obviously, there's no question on this. It's definitely psoriasis. A regular pit, do you remember we say in the class, is alopecia areata, and the irregular pit is definitely psoriasis disease process, and that is obviously a classical, no confusion on something like this. This alopecia areata would be a regular pit, regular pitting. Lichen planus would have something like, LP would have something like pterygium formation, would have thinning of the nail. We do discuss that also. We have ridging also of the nail. We also have tracheonychia. All these are features of lichen planus of the nail. This is obviously a question on psoriasis of the nail, right? Third question. Fourth question, again we discuss this routinely. Old man, all right, erosion on the nasolabial area. We remember the most common site, and I put a star on this sentence. Most common site of BCC is the nose. Do you recollect this in the notes? We have this in the notes, and this we remember is a rodent ulcer. Remember this, we write that also. So old man who's got a cumulative sun damage coming over 65 years. Okay, now histology is shown. Now in this histology, obviously the theory itself tells you it's BCC, and the histology also is a basal cell cancer. You can see these nests and the lobules of basal cells, basaloid cells. These are lobules and nests of basal cells, because basal cell cancer comes from the basal cells, basal epidermal cells. So you have in these cells a lot of basophilic nuclei, more basophilic than the routine basal keratinocyte. So a lot of bluishness will be seen, which you can appreciate here, and there will be a nest, a palisading of cells at the edge also. So even if you don't really pick up the histopathology, at least you can pick up the theory, and the theory itself gives you very classically this. Melanoma would obviously be pigmented. There will be melanin there, so obviously it doesn't make sense. Mycosis fungoides would have something called as a Potrier microabscess on histopathology, and an epidermotropism. All this we discuss inside the class. I'm not going to discuss the theory here, it's just an indication of the MCQ and the answer. We are not here to do theory in this discussion. So Potrier's microabscess will be a lymphocyte collection in the epidermis, right? And epidermotropism will be there. Basal cell cancer will usually be a cauliflower growth, and these will be squamous cells. Okay, squamous cells, which will be the histopathology, not the basal cells. The blue itself means the basaloid cells or the basal cells, and obviously that will be a BCC, basal cell cancer. No confusion on this. All these four covers, if you see up till now, have been covered in your notes already, so that is easy then for you to answer. Again, we covered this also very prominently inside the class. A patient of leprosy with painful lesion around the eyes and the center of the forehead. Now they had, now see, images can be variable because obviously I'll not get the same image, but there's some lesion on the forehead and around the eyes. In fact, I do mention that when I discuss the one-liners of leprosy, when we start a leprosy topic, I discuss one slide on something also single line MCQs on leprosy. In that we do write the most common cranial nerve involved. Most common cranial nerve involved is facial. Most common cranial nerve involved is facial, right? And the second most common nerve involved is trigeminal. The second most common cranial nerve involved is trigeminal. But we don't have to worry about trigeminal here. We are focusing on the facial, which I in fact show you an image of Lagophthalmos. Okay, of Lagophthalmos in the discussion that we do in the class. Lagophthalmos means paralysis of orbicus oculi muscle, and it doesn't close. So obviously eyes are exposed, exposure keratitis, corneal blindness can happen, opacities can happen. So obviously no problem on this. Now some students said that no, because on the face will mark it trigeminal. No, trigeminal is not a very common nerve as compared to us. Plus, when the trigeminal, the maxillary branch of trigeminal is more commonly involved, not the upper part. Okay, so maxillary part is more involved than the facial. So the question says, see this eyes and the center of the forehead, this is the upper face, right? So there the trigeminal, that part of trigeminal is less involved. It's usually the middle face. So if the question would have said some leprosy on the middle face, still we could have a confusion between whether to mark trigeminal or whether to mark facial. But just around the eyes, there's absolutely no confusion. It's a paralysis of the motor fibers of the facial nerve, which is always a danger for any lesion around the face. And that's why when you have a edema or some kind of inflammation on the eyelid, You want to give steroids very fast, and if it's a type 1 lepra reaction, usually it will be a type 1 lepra reaction around the eyes, and they will put in a steroid to reduce the inflammation so that the facial nerve complications and the affection is going to be a bit reduced and the nerves can recover. You give MDT and put in some steroids quickly to avoid the paralysis of that orbicularis oculi muscle, right? Okay. So again, all the 5 questions up till now, 100% coverage in your notes. A lady with body mass index of 30, again, this is something that I do as a part of my focus on nutrition in my classes. This means it's obesity, obviously, right? Obesity with falling physical finding. We show you this almost the same images. This is definitely acanthosis nigricans. This is acanthosis nigricans, right? And this acanthosis nigricans will be this black velvety hyperpigment. We call it velvety hyperpigmentation on the neck folds, axilla and all. And this is a part of what is called as metabolic syndrome. We do mention about insulin resistance, metabolic syndrome. So this comes because people are becoming more fatter, and the reason for that obesity is because they are insulin resistant. And when they're insulin resistant, because of insulin resistance, they have secretion of ILGF, insulin-like growth factor. So growth factor means your epidermis starts becoming thicker, and it starts becoming thicker, it starts becoming blacker. And that is what you can appreciate initially on the neck folds, axilla and all that. So along with insulin resistance not only acanthosis nigricans come, they might be developing a bit of diabetes or a bit of atherosclerosis, a bit of non-alcoholic fatty liver disease, PCODs. All these kind of are together as a symptom of hyperlipidemia coming in. All this is a sign of metabolic syndrome. So metabolic syndrome is a term that we use for a constellation of features which has commonly insulin resistance as the core of that problem. And what comes out of that insulin resistance is acanthosis nigricans, sometimes a bit of lower face acne, some hirsutism coming in, central obesity coming in. Central means like abdominal obesity coming in, PCOD, fatty liver, non-alcoholic, that is, some kind of hypertension, hyperlipidemias, coronary artery disease, strokes. All this is a constellation. These are all same diseases, right? And that really comes from this. So it's basically something which is very prominent in our Indian population, which is becoming more and more insulin resistant. So again, 6x6 coverage in your notes. Now 7x7 coverage in your notes. This is again there. Again, pick up your notes properly. Anogenital warts comes to you. Histology is already showing atypia. Now the most common cause of angenital wart is HPV 6 and HPV 11, right? Now these are what is called the low risk HPV. But in our notes, we also discuss the concept of high risk HPVs, right? High risk usually creates cervical cancers, right? But obviously you can have anogenital warts also as a part of that. So when we talk about anogenital warts, you can either have a low risk or high risk possibility. The more common of external genital warts, the condyloma acuminata, the most common is 6 and 11, but obviously you can have the high risk types also. The question is directly saying there is atypia, meaning there is obviously a high risk population there, and for that we'll call it as HPV 18. So we have HPV 16, 18, 31, 33, then 45, 52, 58, right? These are your high risk viruses which are covered by the vaccine, which is Gardasil 9. Okay, when you say 9, it also covers 6 and 11. So that becomes like 9 viruses to be covered by this Gardasil 9. So that is usually the best overall coverage that we have to prevent the HPV disease, and obviously further preventing the carcinogenesis. Wrestler, this is that overlap with microbiology, right? A lesser but you have covered this again in the notes. A wrestler covered with itch in the axilla, lesions of central clearing. I told you in all my classes the central clearing by definition means tinea. Tinea we know is also itchy. So we are definitely looking at tinea disease. If you remember, I told you the most common cause of tinea is Trichofaton rubrum. Nowadays, Trichofaton mentagrophytes also is increasing its possibility. Okay, so we do cover this inside the class. Now let's go ahead. Red velvety colony. The moment you said red, the reason something was called as rubrum means red, right? So that is why it is simply red. So you kind of have to take a little bit of microbiology help also here, but by itself also you know what's happening. They have pencil shaped macroconidia. Now pencil shaped macroconidia is something that you do see in Trichophyton. The entire group itself has pencil shape. macroconidia, and they also have abundant microconidia. Okay, remember epidermophyton does not have microconidia. So the answer, but the thing is, all of them have trichophyton only, no? So what you have to know is Trichophyton tonsurans usually is Taenia capitis. Trichophyton schonleni is also Taenia capitis. So you have to decide between rubrum and mentagrophytes. Between them, you just pick up the colony, the red colored rubrum colony, and that is how your diagnosis gets made. You can still pick it up from what we have discussed. Ninth, and this is again, this is something that is more of a microbiology question. So we don't routinely cover this inside the dermatology class, okay? But still, if see, because there's a rash in the question, so I still picked it up. See if you can pick this up. A military person staying in a crowded basement gets itchy rash on the body, sparing the palm and the sole lice. Now, it's a louse-borne or a lice-borne infection. The classical cutaneous infection with lice, I'm not talking about systemic. The classical cutaneous infection is pediculosis. But here there is a bit of rash, bodies sparing the palm and the sole, crowded basement, everything is mentioned. And the options are all rickettsial diseases. So there's obviously a systemic thing. The answer on this is Rickettsia prowazekii, which creates what is called as epidemic typhus. Now, this was a disease which was really rampant in those Nazi concentration camps, by the way. During World War II, when prisoners were captured, they had actually louse on their body, and they could transmit those louse species between prisoners. So there was a cramping, and everything, everybody was very close by. This epidemic typhus usually has fever. It has a rash which does not go to the palm and the sole. That's what the feature is. You could get in those prisoners of war in the Nazi time had a lot of delirium, stupor. They could even die with that disease because at that time the drugs were not freely available. So that is Rickettsia prowazekii, which is a louse-borne epidemic typhus. Akari is caused by a mite. Conori is going to be a tick, and typhi is going to be a rat flea. Okay, this rat flea is endemic typhus. This rat flea is endemic typhus. So the answer here is going to be, because it says louse, that itself gives you an indication that it's going to be rickettsial species. This is going to be epidemic typhus. Epidemic typhus. Okay. And the last question, okay, the last question, this again we have covered inside the class, foot swelling and sinus. Now remember this, I showed you that there's a local foot swelling, there's a triad of mycetoma. We do this in the class, triad of mycetoma, and we say there is a sinus, there's a grain, and there's a swelling. So if I look at the theory, see the swelling, sinus, and the grain, that itself tells you that the diagnosis by itself is a mycetoma. Now, when we talk about mycetoma, we do say there are two types of mycetoma. Remember that, fungal mycetoma and a bacterial mycetoma. The histopathology that they're given is of the grain. Now, this grain actually is the colony of the organism, and they have this radiating outward kind of an appearance, which is called a sun ray appearance, like how the sun have rays on their edges, right? That's called the sun ray appearance of the grain. But even if you could not really identify the grain and the sun ray appearance, you would still be able to answer the question because you have all the three features, right? And now if I look at the mycetoma, then how do I answer this on mycetoma? They wanted you to pick up the correct statement. Now this is obviously what we discussed, right? Bacteria and fungi, both eumycetoma and actinomycotic mycotic mycetoma, does not invade deep tissue is wrong. It definitely is a deep fungal infection. It goes right into the foot to create a sinus and a grain. You cannot have a superficial infection. Tinea and pityriasis versicolor is a superficial fungal infection. This is what is called a deep fungal infection. In fact, mycetoma, chromoblastomycosis, porotrach, all of them are deep fungal infections. Hematogenous spread, is it coming from hematogenous spread in your body? No, it's coming from a thorn prick, right? And again, we do say that it comes externally from a thorn prick. So it's not coming, some diseases come through hematogenous spreads, right? For example, carcinoma can be hematogenous spreading to other areas. This is a thorn prick creating the problem. Splendor-Hopley phenomenon is nothing but the other name for asteroid bodies. Splendor-Hopley phenomenon is asteroid bodies, and we do say that, that's in the notes, we say that it's covered, it's serine porotrichosis. Okay, what is asteroid bodies? You have this fungal organism, okay, of Sporothrix, And around that we have these radiating red colored fibers. Can you see this radiating red colored star shaped? Can you see this star shaped? And that is called splendor Hopley, or asteroid, like a star. So obviously that is not a part of mycetoma. So answer would be both bacteria and fungi create this whole thing, right? So you can see this is this 7 questions, complete dermatology, 3 a little bit of an overlap with microbiology, right? And you could still, however, pick up some clues in the question if you had a presence of mind even in those 3 questions which were separately, right? So these are my 10 questions. I hope you got most of them correct in this session. My best of luck to you, and keep reading, keep revising. Thank you.